So without any further ado, I'm going to try to move on to the title slide, Chemo, Brain, Chronic Pain, and Depression, they're not all in your mind. And all in your mind is because a lot of times with these kinds of conditions, people who have complaints about the symptoms are not always taken seriously. And we'll talk more about that later, but they are often told, well, that's all in your head, and it may be literally in the head, but not just in their mind in ways that we'll see in a moment. And as a consequence of that, if someone, say, is depressed for a period of time, they may be told by well-meaning people, well, you just got to snap out of it. Well, as we'll see, that's like telling somebody you just got to snap out of cancer, or you just got to snap out of your diabetes. These are just as biological, just as physical, and just as imageable as a tumor is in any part of the body. And it's just that you need the right imaging tools in order to be able to see beyond the scalp and the skull that covers all that up normally, to be able to see what's going on in oftentimes the brain and sometimes in other parts of the body as well that's contributing to these conditions. And one of the tools that we'll talk a lot about, because it's been especially powerful in being able to do this kind of imaging, is a PET scanner. And originally, when these kind of conditions began to be looked at, the PET scanners were sold as standalone scanners. Now, almost all the scanners that are sold for clinical use are sold as scanners that have both a PET and a structural component, like PET CT most commonly, or more recently, PET MRI. And when that's done, you get two kinds of information within the same scan. And what you're seeing here is a PET MRI scanner. You're seeing the whole body from the front type of looking at the patient as if they were looking standing in front of you, and then from the side. And then you can also do dedicated views of certain parts of the body, and most interesting for purposes of today's talk, the brain, and see kind of exquisite detail of the anatomy is shown up by the MRI or CT, and also the function that's overlaid on this hot metal scale that ranges from red to yellow, as presented by the PET data superimposed upon the MRI data. And one thing that I think Aaron is prepared to do is, if you have questions as we go along, put them into the chat box. You don't have to feel like you need to hold everything to the end, because we want to keep everything as clear as possible for as many people as possible. And also, I always think there's more to be gained by a discussion than by a lecture in any event. And so comments or questions that you have, feel free to enter them along the way. And Erin will keep her eye out for them and bring them up as looks like appropriate times. And so here's a good example of, in a single patient, the difference between functional versus structural imaging, in this case, using the PET scanner and the structural imaging scanner, the CT, separately. So this is a patient who had a PET scan, not for the purpose of evaluating brain function originally, but because they had a tumor, and it's a head and neck tumor. And things that are darker here mean that they're more metabolically active. They're using more glucose, and so they're taking up more of the PET tracer for glucose called FDG. And so you can see there's this very metabolically active tumor in the neck, and it's primarily on the left side of the neck, because when these, just like someone standing in front of you, what you see on your right is the left side of their body. What you see on your left is the right side of the body. So it's primarily on the left side of the neck, but it's so active and so large that it's crossing over to the right side of this patient's neck. And when it's doing that, it actually turns out that it's impinging upon the carotid artery, which is the main artery that supplies all the blood to the right side of the brain. And that was evident in a CT scan that was done with contrast. So the contrast agent is injected into the veins, and then they get carried up to the arteries as it passes through the circulation system, and including the arteries that go to the brain. And what you see in blue is what's normal. You're seeing this contrast that's white filling up this carotid artery on the left side of the brain. But if you see on the right side, there in that same corresponding part of the carotid artery on the right, there's no contrast entering at all. And in fact, the only thing that turned out to be keeping this patient's right side of the brain alive was what we call collaterals, that is some crossover arteries a little bit higher up that carried some of the excess blood to the left side over to the right side, but not nearly the normal amount. And so when the CT scan was read for the brain above the level of the carotids, it looked like a pretty normal CT scan with no obvious asymmetry. And you can see that from top to bottom here, that the left side and the right side of the CT scan look very similar to each other. But when using the functional imaging modality of PET, you have a very different picture. And if you look here, for example, the brightness on the left side as shown in blue versus the right side shown in red is you don't need to be a radiologist or nuclear medicine physician to see that this left side of the brain is much more active than this right side of the brain. And that's because the right side isn't getting enough blood, so it's not carrying enough oxygen, not carrying enough glucose to carry out its normal functions. And so even without a stroke or something as dramatic as that, it has vastly diminished function for half of the brain. And that's something you would never be able to see with any kind of structural imaging, CT or MRI in its structural mode, because this is purely a functional consequence of not having adequate fuel to carry out the functions on that side of the brain. And another thing you can see here is if you go down to near the bottom of the brain, these are horizontal slices going from top to bottom. When you get down to the cerebellum, you see just the opposite. And you see that the left side of the cerebellum is very diminished in activity. And why is that? Because that's not dependent upon the carotid blood flow, but it's because the left cerebellum receives most of its input, or a lot of it, from the right side of the cerebral cortex above it. So when this activity is diminished, the activity being received here is diminished. And again, this is purely functionally imageable, something that you can image functionally purely, because there's nothing wrong with the left side of the cerebellum or its blood supply. It's strictly a functional consequence of not getting adequate information from another half of the brain. So this shows kind of the power of functional imaging to see things sometimes more sensitively and sometimes more specifically than structural imaging, and sometimes that you wouldn't be able to see at all with structural imaging. And where that's come up most in clinical applications, there's a lot of research applications, as you can imagine, for this, but in clinical applications, most commonly is one of the most common and severe diseases to affect the brain, and that's Alzheimer's disease. And when patients go through a complete workup in the conventional way, they get a history and a physical, and they go to a neurologist, get a neurological exam, and they get laboratory bloods values, and they get neuropsychological testing if necessary, and even an MRI structurally, as you've just seen, when that's indicated. The overall accuracy that the dementia expert can make in the absence of having functional imaging information is at best 60 to 70%. If you have them say with every patient, does this patient have Alzheimer's disease or not? But if you add in the information available by functional imaging, you can boost that to in the 90s. And you can see why. Here's a patient who has, is shown in the red arrows, diminished metabolism in this back part of the brain, and also kind of the center of the brain here called the posterior cingulate. These are the parietal and temporal lobes. And you can see that's much less dark than the prefrontal area in front of it, which is what you see in the earlier stages of Alzheimer's disease. But you don't have to wait till the patient has Alzheimer's disease. If you look on this slide, that the bottom is showing an Alzheimer's patient with that reduced metabolism here. Above that is a patient who just has mild cognitive impairment, meaning that they would not qualify by clinical criteria for having dementia, but they have some memory changes. And if those memory changes are in fact due to early Alzheimer's as opposed to something else, they will have the same kind of pattern where the back parts of the brain are decreased in metabolism compared to the front parts of the brain. And even at a stage before they would qualify for mild cognitive impairment, meaning that they're normal relative to other people of their age and level of education, but not necessarily as good as they used to be themselves, what sometimes is called age-associated memory impairment. You can already see the beginnings of these decreases in metabolism. And this is, I should say, it's a rainbow scale. It's just like a rainbow has red on the top and then orange, yellow, green, blue, indigo, violet. Things that are more metabolically active will be red or orange or yellow, and less so green or blue. So you can see the front of the brain is still in this red, orange, yellow level, but the back of the brain is in this green, blue level at a time that they're still considered to have no definable diagnosis, just different from what they normally would be able to perform cognitively for themselves. And so this is a patient who, going to the doctor, is told, oh, you don't have anything to worry about. You don't have Alzheimer's, you don't even have mild cognitive impairment clinically, and you don't have evidence of it on any of the kinds of tests that we've done. But in fact, if they had a PET scan, you'd be able to say, well, you have a condition that about 6 years from now could lead to full-blown Alzheimer's disease. We've seen plenty of cases like this. And we have a sensitivity such that if the Alzheimer's process is going on in the brain, even years before it'd be diagnosable with actual Alzheimer's disease as a dementia, that we have a 95% sensitivity for being able to pick up these kinds of abnormalities. So a couple years ago, we wanted to kind of extend beyond this most common use of PET for looking at brain function to look at things for which there had been increasing attention to in the news, and things like chemobrain and things like post-traumatic stress disorder and things like brain injury in athletes or in soldiers who are coming back from combat. But there had been just much less study of them from a research perspective in terms of what's going on in the brain. And very rarely are medical imaging tools used clinically, although they are used for increasingly to help learn about these conditions from a research perspective. And so I'm going to share with you what in these cases, what they all have in common is, like Alzheimer's disease, they can have very long lasting consequences for brain function that can't be seen from outside the body. And, you often hear, soldiers, for example, say that, they would rather have that had, a leg amputated because everybody can see their injury. But when the problem is inside the brain, nobody sees it. And then, again, you get a lot of times this kind of attitude where you need to snap out of it, you need to pull your stuff together and so forth, which is like saying, again, you need to snap out of whatever, of having your leg missing. So we'll talk about that first, the chemotherapy in depth. But before getting to that, some of these other conditions like traumatic encephalopathy that comes from having repeated blows to the head is something that we've learned a lot about in the last decade from the news media and from big settlements with the National Football League and so forth, that this can lead to cognitive changes, even dementia at an earlier stage and otherwise would occur if it would occur at all. And also motor symptoms like Parkinson's disease. And that's been appreciated really for, in the case of professional boxers, for example, for more than a half a century, but only has been systematically studied more in the last decade and a half when this has come up, largely because of legal issues. And I'll focus your attention first on the left side of the slide, which is the symptom side. And so this red area and its intersection with the yellow area and the blue area are typical symptoms of cancer and chemotherapy-related cognitive impairment, or what's often called chemo fog or chemobrain. And it overlaps with post-traumatic stress disorder, shown in blue, or traumatic brain injury for some symptoms, like memory deficits and concentration. Overlaps with traumatic brain injuries for some other symptoms, like executive functioning, ability to maintain attention and focus on things, ability to process things at a reasonable speed. And then there are some things that are more characteristic of this than the other conditions, including problems with verbal skills and problems with visual spatial abilities and problem solving more generally. And all of these things are reflected in changes in brain function that we can not only see, but we can measure and quantify. So for this overlap in post-traumatic stress disorder and cancer-related cognitive impairment, we can see that the prefrontal portion of the brain has been identified as being abnormal in its function in all these patients. And where all these things overlap in this kind of brownish orangish area, the areas that are important for memory formation are affected measurably by these kinds of sensitive imaging tools. And then for traumatic brain injury and the cancer-related impairments, the cerebellum is proved to be an area that we've seen most consistently show up in a lot of the imaging studies, which I'll just give you an example of how we're able to identify those. So the first study that actually showed changes in brain metabolism in patients who had had cancer and chemotherapy, and then following that long-term symptoms of not being able to function cognitively as well as they used to, was actually done here at UCLA. And here's an example of one of the very first patients compared to two kinds of controls. So here's a 55-year-old woman who had cancer and chemotherapy compared to a 55-year-old woman who had the same cancer, breast cancer, but no chemotherapy, and then also a healthy control, that is no breast cancer and no chemotherapy. And again, on this rainbow scale, you can see that parts of the brain that normally are very active, this red, orange, yellow area, that would be an area that's really important on one side of the brain for expression of visual information, language information, on the other side for visual information. These are substantially reduced in these patients that have chemotherapy after having had cancer diagnosis. And that's compared to both patients who've had the cancer but not the chemotherapy, and also to patients that have not had cancer or chemotherapy, of course. And in the left side, this coincides or overlaps with an area called Broca's area, which is an area that we know to be critically important for expression of language information. And the right side for also articulating kind of non-language information. And then another area that's kind of right here in the front is an area that normally goes down with normal healthy aging, but we're seeing this green that should be red, orange, yellow, a level of metabolism that in a 55-year-old would be more typical for an 85-year-old. So kind of like accelerated aging of this part of the brain that's really important for executive function, for attention and focus and so forth. And you can say, well, that's fine, but how do we know that those changes in brain metabolism are really related to the problems that they're having cognitively? And so one way to do that is to look at how those compare. And all these patients in this study had a neuropsychological battery of 21 neuropsychological tests. And the single test that the patients with chemotherapy had done worse on compared to the patients not on chemotherapy was this what's called complex figure delayed recall. And the way it works is they're asked to look at this figure and then say if they, and while they have it in front of them, their ability to copy it is tested. And then it's removed. And a half hour later, they're asked to remember as best as possible what the figure looked like and to draw that on a piece of paper. And so you can see this is something that wouldn't be easy for anybody, even before cancer and chemotherapy. And that's part of the point, which is to say that these deficits are subtle enough that it takes a complex task to really bring them out the most. But if you look at how well the patients with cancer and chemotherapy did on this test, or how impaired they were, and ask, are there any parts of the brain whose activity correlates with that impairment? It turned out, now you're seeing it from kind of side view or the other view turned over on its side, that that same part of the brain that you saw back here as being diminished is the area that correlated best with impairment and the ability to do that particular test. And then another way to ask the question about how do we know these changes in brain function are related to the problems that we're having cognitively seeing in these patients is to actually do the scan while the patients are performing the test of a memory test. So in this case, it was a verbal memory test. And the way it works is that there were many pairs of words, such as lonely waitress, cheerful waitress, among another couple dozen, that are being presented to the patients. And then either 10 minutes later as a test of short-term memory, or a day later as a test of longer-term memory, they're shown just one word, in this case, the keyword waitress, and asked to recall any word or words that they previously remember having been associated with that keyword. And while they're doing that, the PET scan is actually taking a picture of the activity of their brain. And in order to make it specific to that memory task, there's a control task where they're just shown a word and asked to read it and repeat it. And so the same thing's going on with their eyes and their sensation, that is, they're seeing a word on a computer screen. The same thing's going on in terms of their motor response, and so that is they're articulating a word with their mouth. But what's different is the mental process in between that input and that output. And so the difference between those scans is a specific reflection of what's needed to actually remember something either 10 minutes before or the day before. And the protocol is to do that baseline task of read and repeat, and then the short-term memory task of things they've seen 10 minutes before, and the long-term memory task of things they've seen the day before. And then in order to control for order effects, to go ahead and reverse that and do the long-term task and the short-term task and the baseline task. And then we can essentially add across the baseline task and the short-term task, the long-term task, and say what's different in the brain function during performance of the memory test that's different than when they're just reading and repeating. And after all that's done, then we can follow up with the kind of brain scan that I've been showing up till now, which is looking at the metabolism of the brain when they're not doing anything but resting. And it turned out when we look at that kind of activation study, that is what increases in the brain activity when the patient's doing a memory task. On the left, we're seeing the group of patients who had been exposed to chemotherapy. And you can see that these same areas of the brain we saw in the previous representations, the side area that includes like the Broca's area, and then this top area that is involved in normal aging, are the same areas that are particularly active in this patient, in the group of patients who have been exposed to chemotherapy, but very minimally active in other patients who have their main activity in the back of the brain, where patients who have been exposed to chemotherapy also do have activity, but there's this huge, what you might call frontalization of the response. And if you put that together with what we saw in the beginning with these scans, where there's diminished metabolism in these same parts of the brain, what it seems to be saying is that since these parts of the brain are kind of diminished in their ability and their function as represented by the lower degree of metabolism, that they essentially have to work harder to carry out the same memory tasks. And if the tasks are simple enough, they may still get the right answer, but with much more difficulty. And this is often translated in symptoms, and the patients will say, oh, it's so tiring to do the things I used to do, even to think through things that were relatively simple. And it's a complex enough task. Yes?
Hi, Dan. I just have a couple questions that have come up. One is for the research being discussed, how far post-chemotherapy are the patients?
So at the first paper that we had published back in 2007, all those patients were at least 5 to 10 years out from their last dose of chemotherapy. And there have been subsequent papers showing that even patients 20 years out can show lasting effects evident on their brain imaging. But effects show up much earlier than that. You can see effects showing up in the first month after chemotherapy. Nobody's surprised about that because they're still, reeling from the direct effects of chemotherapy or some indirect effects of having, the diagnosis and the therapy to deal with. But to see these effects long after the chemotherapy itself has left the body is what really attracted a lot of attention to this. And in fact, one of the things that I would hear that patients would say to their oncologists, who had often kind of diminished their patients' complaints when the patients would talk about these things, is they would say, you see, it's a thing, because they could see with their own eyes in black and white or in living color, these changes occurring in the brain who people have been exposed to chemotherapy, even years later. And in terms of symptoms, the majority of patients will have some symptoms during the time they're going through chemotherapy and shortly after. But by the time patients are at least 2 years out from the chemotherapy, most of them recover back to the normal level or very close to the normal level of cognitive function, but there's still a substantial portion, about 20% or so maybe, that do not.
Dan, another one, well, we've got two more. Is the chemobrain preventable? And then from the same person, are there all types of chemo? Is it the same for immunotherapy? And how can we help our patients prior to starting on chemo to minimize the impact on their brain function?
Okay, so for the preventable part, I'll save that for part of the talk that's coming up in a little bit, because that kind of gets down to what the mechanisms are for that, which we're just beginning to get a better understanding of. And in terms of well, yeah, so let me, I think if these questions aren't answered by the time we get to the end of this part of the talk, then let's bring them up. But I think you'll get a lot more. So in terms of the question about does it matter kind of what kind of chemotherapy and immunotherapy and so forth? So it doesn't matter as much as you might think it would. That is that we've seen similar effects on cognition for a wide array of chemotherapy agents or combinations of chemotherapy agents. And part of that is probably due to the mechanism we're talking about. But it can matter in terms of the classes of chemotherapy agents that are involved. For example, normal cytotoxic chemotherapy agents that people hear a lot about, like paclitaxel or cyclophosphamide or methotrexate, fluorouracil, the adriamycin. Those can all have these kinds of effects, but a whole nother type of chemotherapy or a drug that's used in the course of chemotherapy are in breast cancer patients, and a kind of analogous group in prostate cancer patients, are drugs that affect the sex hormone axis. So in the case of tamoxifen, it's blocking estrogen in people who have estrogen receptors on their breast tumors. And we asked the question, if people are getting both of these classes of chemotherapy agents or drugs to control their tumors, does it make a difference? And so what you're seeing in the leftmost bar are patients who are getting chemotherapy and tamoxifen, compared to those in the orange bar getting chemotherapy only. And then again, the kinds of controls, the breast cancer patients with no chemotherapy and also healthy controls. And although there was no significant difference in this one particular part of the brain called the basal ganglia, with lentiform nucleus, part of the basal ganglia, for patients who were getting chemotherapy only, there was a significant difference between the controls and the patients who had cancer but getting chemotherapy only in the activity of that part of the brain if they were getting both the hormonal therapy and the chemotherapy. So that's an example of a change in brain function that does go along with at least classes of chemotherapy agents that are being administered. And just to put it in kind of very simple terms, what the basal ganglia, like the lentiform nucleus, is especially responsible for is having executive motor response to what is being cognitively processed. So it's kind of what connects what you're thinking with doing something about it. And this corresponds to what we often hear. The patients will complain, they'll say, yes, I know I need to do this certain thing, or I see this thing across the room and I got to do this, but I just can't bring myself to get it done. And that corresponds to having less metabolism in parts of the brain that are very important for doing that. So to conclude from what these first studies were showing us, these abnormal regional brain activity patterns were being identified. In this case, they were breast cancer patients, but since then it's been shown for lymphoma patients and patients with multiple other kinds of cancer. And the activation pattern during a short-term recall task was abnormal, particularly in this part of the frontal lobes that are important for executive functions and attention and focus and so forth. And that severity of that abnormality correlated with severity of the inability to do things that normally they could do that involve short-term memory. And also that the metabolism while at rest was changed in not only those parts of the brain, but also in the basal ganglia parts of the brain in patients who also got tamoxifen, but not if they had chemotherapy only. And since the time that we published that in 2007, there's been 8 other groups that have published very similar things using FDG PET scans, and even more groups that have published using other kinds of functional imaging modality like functional MRI. And the most common changes across these different studies that are reported are the ones that we reported back in 2007. We talked a lot about the frontal cortex. We didn't talk a lot about it because of the time, but also the second area most affected was the cerebellum. And so these are robust findings across different kinds of cancers, across different kinds of chemotherapy, and across different modalities, even structural imaging modalities like the MRI we talked about before. What you're seeing on the right side are the data I showed you a few minutes ago with the PET changes in activation in this prefrontal parts of the cortex, where Broca's area is, and inferior frontal gyrus, and then this more superior frontal medial part that's important in aging. And what you see here is a completely different study, not looking at function, but looking at the gray matter density, that is the amount of tissue of the neuronal cells where they connect with each other that's actually present, and how that's shrunk after chemotherapy. And you can see a remarkable correspondence. Here you see the cerebellum, here you see the cerebellum, here you see this inferior frontal gyrus, including Broca's, here you see that, and here you see that more superior frontal gyrus, and here you see that, with the areas that were specifically affected by chemotherapy in the functional imaging that we did with PET several years earlier in a different part of the world, in a different group of patients, different set of machines, showing again kind of the robustness of the findings, but also showing the power of something as sensitive as functional imaging, because these patients were a month after chemotherapy showing these shrinkages. But when they looked a year later, most of these changes had reversed and they weren't statistically significant anymore. But as I said, even 5 or 10 years out, we were seeing long-term changes in these parts of the brain in people who had these cognitive problems after chemotherapy. And then to get to the kind of last part of this is, what's behind all this, that is what's causing this change in brain function in people who've had chemotherapy. And there's a lot of potential influences and a lot of hypotheses, but one that's been kind of best explored and probably the strongest working hypothesis in the field is that even for chemotherapy agents that don't get across the blood-brain barrier in high concentrations, and a lot of them do, but even the ones that don't, can still cause release from either the cancer cells or cells of the immune system of these factors called cytokines, which can get across the blood-brain barrier and are known to have toxicity to brain tissue. And so the chemotherapy agents are known to be able to boost these cytokines, cross the blood-brain barrier, and then have these negative effects on not only the brain tissue, but on the corresponding cognitive function. And so we looked at this empirically. I'll just get to kind of the bottom line of a paper we published a few years after the initial showing of change in metabolism. And we said, how does the changes in metabolism that we see a year after chemotherapy correspond to changes in the cytokines that we see right after the chemotherapy, with the idea that even if the cytokines go back to normal, they may have initiated damage to the brain tissue or changes in the brain tissue function that are much more long lasting. And in fact, what you're seeing in all these colored areas are areas where there's a significant correlation between these cytokine levels at the baseline compared to the metabolism a year later. And these are all cytokines that are markers for inflammation. So an inflammatory response to the cancer and chemotherapy. And you can see that for 3 of the 4 of these markers, that this prefrontal area of the brain is significantly affected. And for all 4 of the markers, this other area of the brain on the lateral surface, the outside surface, that's part of the anterior part, the frontal part of the temporal cortex, this lobe that's down here, is affected in terms of being well correlated with the levels of metabolism here compared to the levels of the cytokine a year before. And yet, you can say, well, how do we know this has to do with chemotherapy per se? In the patients who didn't have chemotherapy, none of these correlations pertain. These were not significantly correlated a year out. So you can have all sorts of things that lead to changes or fluctuations in cytokine levels and in brain metabolism, but they're well correlated only in the patients who've gotten chemotherapy. All right, so I'll pause there to see, before we move on to a different topic, any other questions or comments about this part of the talk that Erin would like to bring up from the chat list.
Yep, Dan, there's another question. Is there a similar response in the brain with cytokines in sepsis?
So there are massive releases of cytokines in patients who are septic, and exactly which cytokines and how much depends partly on the mechanism for that sepsis. And certainly a lot of those are getting across the blood-brain barrier, but I haven't seen the same kinds of measures of cerebral function of cerebral metabolism in relation to that that we've seen across these last decade and a half with numerous modalities, but including numerous studies from different centers doing FDG PET. I'm sure there's some. I'm just not familiar with it personally. I can't say I'm sure there's some. There's likely some. Other questions or comments?
There's another one, Dan. Same may apply for patient with autoimmune diseases, lupus, psychosis, etc.
Yes, so autoimmune diseases do have effects on brain metabolism. And in those cases, well, there's 2 kinds. There's things like lupus, like was mentioned, that can often have a secondary effect on metabolism because they can affect the blood supply to the brain and cause changes like vasculitis that can impact on patients' cognitive abilities. But because of the blood supply disruptions and the disruptions in the delivery of nutrients and glucose and oxygen fuels and so forth, there can be secondary changes in metabolism. So that can be difficult to tease out. But also there are autoimmune conditions. Some of them are related to cancer, paraneoplastic conditions, where there's immune response to antigens on the cancer cells, proteins on the cancer cells, that then cross-react with proteins in the brain and can cause neurologic symptoms. In fact, sometimes the first sign that there's any cancer in the patient's body is, they have a lung cancer, especially like small cell lung cancer, is not anything to do with their respiratory function, but actually some neurological symptoms. And then that might precipitate a workup that then leads to the identification of the cancer. And so in those cases, yes, there's a well-established connections in the patterns of brain metabolism, which we can see with clinical brain PET and patients who have these autoimmune encephalitis, including due to paraneoplastic syndromes.
We have a couple more questions. Would you like to take them now or wait until the end?
If they're specific to the chemotherapy part, let's hear them now.
Well, a couple. One is, do PARP inhibitors impact the brain like chemotherapy?
And what's the other?
The others are, is chemobrain reversible, and are there any treatments?
Oh, so the first question I'll hold off on for now. The second question, reversible by time is what's best studied. And as I said, in 80% of people, there is reversibility within the first couple of years. But for the other 20%, it's not clear that it's reversible, which is to say that we do have studies where there's kind of similar numbers who are out even a couple decades, 1 decade, 2 decades, that have substantial substantial in terms of being measurable, not necessarily substantial in terms of um, how it's impairing their life, although it can, depending on what they have to do in their day-to-day life. We can get more into that later. And so by the time it's been around and hasn't gotten better after a couple of years, it may be difficult to make much impact. There are some things that that are kind of multi-pronged approaches, including programs at UCLA where they have intensive cognitive training and exercise components and stress reduction components, and putting all the, and group therapy, and putting all those things together has shown some impact. How long-lasting they are if those measures stop is not so clear, and how specific they are generalizable to things that aren't particularly addressed during those sessions is also something that's a little more controversial. But what's like almost any condition, it's much better, if not to prevent it from before it even starts, to at least address it as early as possible before it kind of gets stuck in a more permanent type of mode. And so those same things done early on, that is, a strong exercise program, and probably one of the most important things actually is physical exercise, because it causes release of factors in the brain that help tissues that are damaged to actually regenerate and also restore function to them. To do that early on, while those are still more malleable, is important. Getting the right nutrients, including a sufficient amount of protein, since protein is made up of amino acids, and almost all the neurotransmitters, with one big exception, that are prevalent in the brain are actually made from amino acids. And then you have the raw materials needed for the nerve growth factors to then build and restore brain function is important. So that reversibility should start as early as possible to have the greatest chance of being impactful. And I think to give time to the other two main topics, we probably should move on at this point. But there'll be time for general questions and answers later. So I'll talk less about this area, but just developing the same theme, that there are conditions that patients will complain about, and the doctors will do all sorts of tests. They'll do lab tests, they'll do endoscopies, they'll do MRIs and CT, structural imaging, and not come up with anything. And these conditions have often been called functional pain disorders, to mean that it's due to the function, not to the organ. But that's, we know really is not true. And oftentimes it's just that the primary organ of involvement is the brain. And again, we can see that visually. And the very first study with PET that I was involved in after I came to UCLA was an example of that. And at that time, there had been some early imaging studies to look at what we called somatic pain pathways in the human brain, that is on the surface of the body from pinching or burning sensations and so forth. But there had been no studies mapping what was the most important kind of pain from an internal medicine standpoint, which is the pain inside the body, occurring in organs, occurring in our viscera. So in this one paper that we published in just exactly a decade before we had published the paper on the chemobrain, we did two big things. We mapped those normal visceral pain pathways in the human brain. And then we also identified in a group of patients with a functional pain disorder, abnormal activity within that pain pathway. And to get kind of right down to some key findings, what you're seeing on the top is an example at the individual level of a healthy person responding to a pain stimulus. In this case, it's pressure put on the distal intestine. And you can see that if that pressure is not at a level that's painful, this corresponded to 45 millimeters of mercury, there was no significant change in this part of the brain that's really important for pain processing in terms of how we feel about the pain, as opposed to like just judging how, whether it's there or not, or its intensity in a way that doesn't make us feel different. But in patients who had enough of a stimulus, even though it's not that different physically, but enough that they experience it as being painful, normally people have significant activation of that part of the brain. And you can see here in the graph below that, that the level that they perceive the pain to be is very well correlated with the level of activity that increases in this part of the brain. And that's compared to patients who had this so-called functional pain disorder, irritable bowel syndrome. And when the pressure was put on the intestine, even at the painful level, they had no particular articulation of increased activity in the same part of the brain, the anterior cingulate cortex. which is loaded with opioid pain receptors. And so it's a part of the brain that's very important for when it's increasing activity, either reflecting that pain is occurring and being perceived, or even diminishing the impact of the pain on the person's emotional, what we call affective experience of it. And not only that, when you looked across the group of people whom this was applied to, that there was no relationship. So they had some variability in how much activity there was there, although you can see the low levels were much lower than any experience in the healthy group. 1.15 would be up to here, and there's several people below that level. And the high levels were not as high. 1.5 would be up here, and there's nobody near that level. But more importantly is that it's not responding to the pain stimuli. So it's not functionally acting to either report or protect, or both, the stimuli that's occurring in the distal intestine, these people with this visceral pain disorder. And that's now been looked at with many different so-called functional pain disorders called non-ulcer dyspepsia for people who have kind of ulcer type pain but don't have an ulcer when they get it scoped, or non-cardiac chest pain when they have pain that looks and acts a lot like people who have real coronary artery disease type chest pain, that is angina, even responding sometimes to things like nitro, but it's actually not due to the coronary arteries, or people who have irritable bladders. And we've seen, and there's been some publications on all these cases of these changes in brain function correlating with that. One thing to mention before we get to the actual pain stimulus is that what really seems to matter is the anticipation of the pain stimulus. So what we're seeing on the top row, again, this is that same part of the brain, the anterior cingulate cortex, and it's a particular part of the anterior cingulate cortex that's kind of right at the edge called the pregenual anterior cingulate cortex. This top row is the group of healthy subjects who are blindedly told that they're going to get a variety of pressures, 0, 45, 60 millicuries were all given, but they weren't told that the low end was actually 0. They were just told that it would be vary in intensity. And just even when you looked at the 0 millimeter, that is that they're not actually receiving a stimulus, but they don't know it, there was this profound activation of the blood flow in the anterior cingulate cortex that was almost completely missing in the group of subjects who had irritable bowel syndrome. So they're preparing in a way that's activating the part of the brain that's loaded with these opioid receptors for this response. And so how generalizable is this? Well, here's a paper that came out a decade and a half later that is looking at a completely different condition, but also a functional condition, functional dyspepsia, that is patients who have a lot of symptoms as if they have an ulcer or other kinds of gastric type of symptoms, but they don't identify any structural problem in the stomach or the other abdominal contents. And they did the same kind of study. They looked at this blood flow PET type of study. And you can see, I just dropped down to conclusion, that the number one finding that they reported is that these functional dyspepsia patients failed to activate the perigenual anterior cingulate cortex, which is exactly this area that you're seeing here. So it's a finding that is seen across the world in a completely different group of patients in different years on different machines, but that's holding up across these conditions. And there's, like I said, there've been other papers that have demonstrated, for example, in the non-cardiac chest pain, similar type of things. Now, these are very sensitive to how you do the studies. So there's other studies that have different findings, but the fact that you can see this kind of repetition of finding in such a specific part of the brain is another indication that when people are experiencing these pains and the doctors say, I can't find anything wrong, it's because they haven't looked in the brain in a way that's quantifiable, like has been done here. Okay, and then briefly, the kind of last area I wanted to mention is in depression. And one of the best models for studying depression that crosses over from animals to humans was actually discovered by accident. And there was this classical conditioning phenomenon that we've all heard about, Pavlovian conditioning, which itself was discovered by accident. He was actually not a psychologist at all. He was a digestive diseases scientist, and he was trying to study salivation. And he was studying the response of putting food in a dog's mouth to how much saliva was being excreted from the salivary gland. And they just happened to notice that they didn't even have to put, after a while, the food in the dog's mouth. Just the dog realizing it was going to happen caused the saliva quantity to increase, which was originally called reflex at a distance, and then later called psychic reflex, or now we call as a conditioned reflex or conditioned response. And so we've often heard about this with the kind of classical setup of food being as an unconditioned stimulus causing salivation, a bell not causing salivation, but if you pair the bell and the food together enough times, then eventually just the bell by itself will cause salivation. Well, a half century later, and that was happening in Russia, but a half century later across the Atlantic Ocean in North America, this is Pavlov on the left, this is Solomon on the right, was trying to generalize those findings and say, well, that works with food, which is a reward, but would also work with something that the animal is taught to avoid, like electrical shock. And he had another accidental discovery. Here's the setup. And instead of a bell, it was a little bit more modernized, and there was a speaker that they could activate to turn a sound on. And then that would happen in the same time with or just before that a shock was delivered to the floor to a dog that was allowed to jump over to the side that wasn't electrified and could escape the shock that way. And in studying this, he had graduate students who had noticed that after a series of shocks, when they're pairing the audible tone with the soon to follow shocks in dogs who were harnessed so that they wouldn't try to jump over until they were ready to do that part of the test, the dogs became useless for any subsequent experiments that required learning how to avoid or escape shock. And so another graduate student who followed later, a pair of graduate students, were particularly interested in exploring this in depth. And so they are responsible for identifying what we now call the learned helplessness phenomenon. And what they had been expected prior pairing of the tone, that is conditioned stimulus, with impending shock, will condition the dogs to jump over the hurdle more easily, just like the dogs salivating more easily to reward. But what they found instead was just the opposite, that the dogs were more delayed or less likely, if they tried at all, to cross the barrier in time to prevent the electric shock. So it shows the importance in science in both of these cases, Pavlov's and in Solomon's lab, of seeing what you're not looking for. And so these graduate students went on to put the dogs in one of three groups, so they would have controls for this, and the harness was put on, and in group one, they were kept in the harness for some time, and then just let loose. In group two, they were administered a shock that could be stopped by pressing a lever, and in group three, they were administered a shock that lasted a duration of time, and they couldn't do anything about it. And what they found is that when all three groups were put in the box to escape the shock, that the first two groups quickly jumped over the hurdle, but the dogs who learned that they couldn't do anything about it just lay down and whined as they received the shocks. And they, as if they felt powerless to change their circumstances. And in humans, this is also applied. People have done this with things, not necessarily electric shocks they have to jump over a hurdle for, but things like unpleasant noises that they receive, either able to turn off or not able to turn off. And what has been seen in both these cases is that these lead to symptoms that we would identify looking at this dog. You look at that dog is not just cognitively have problems in being able to process aversive stimuli, but he's showing universal symptoms that you can see across the species, within the species, across the species, as you can see here or here, of being depressed. And this has entered the public domain so much that figures like Arnold Schwarzenegger have commented that learned helplessness is the giving up reaction, the quitting response that follows from the belief that whatever you do doesn't matter. And this has been studied extensively, especially by pharmaceutical companies who want to test drugs for depression. And you can do it in mice and rat models in a very rigorously controlled way by putting some of them in a cage where there's a lever and some of them in a cage where there's not a lever to turn off the shock, but there's the electrical grid is the same across both. So both mice are receiving the same pattern of shocks, but the only difference being that one learns they can turn it off and the other one doesn't learn that they can turn it off. And what is found in these rat models is that there's decreases in food and water consumption and loss of body weight and loss of ability to initiate normal active behavior, normal grooming, playful and competitive activities, changes in the sleep patterns, loss of ability to respond for rewards, so what we call anhedonia in people, and also this cognitive component of increasing in errors that is often occurs as part of depression as well. And again, this is so entered the public domain that says sometimes the chains that prevent us from being free are more mental and physical. It's kind of an inspirational poster, but that's really the wrong message. It is perfectly physical. It's just that the physical changes are happening in the brain not say in the legs or in the head, the non-brain part of the head, as indicated here. And just finish with an example of how we know that these changes in brain chemistry are really responsible. So this is a study that was done just a few years ago, looking at these depressive-like behaviors and these rat models that were given this learned helplessness paradigm, showed all these symptoms of depression and so forth. And you can tell this study was done in Korea because 3 of the 5 authors have the last name Kim. And what they found by doing this kind of functional imaging, again, with the same kind of studies that we do clinically in human brains, this FDG PET images, is that there was one particular part of the brain that changed its levels of activity in the animals who were given these uncontrollable shocks, and especially if they were showing poor coping mechanisms for those shocks. And in the interest of time, I'll just get kind of the bottom line, which is that if they gave a neurotransmitter that could boost, that could alter level of activity in the parts of the brain that were not functioning as well in those who had learned helplessness and not a good coping strategy, they could completely reverse this almost instantaneously. So overcoming learned helplessness, how to become optimistic and self-dependent. So even if you can't quickly or replace the effects of a poor childhood or low self-esteem with those of good ones, this line of investigation suggests you may be able to quickly ameliorate them through placing the right neurotransmitter in the appropriate region of the brain. And we've known for decades that we can modify the neurotransmitter levels in other parts of brain chemistry with various kinds of antidepressants. And in more recent years, we've seen, and with electroconvulsive therapy, can do it in a much faster way. And we've seen in recent years ketamine being having these rapid response effects as opposed to the antidepressants that usually take a few weeks to have their full effect. In a very similar way in that case as that neurotransmitter that's been placed in that part of the brain that we saw in the rats a moment ago. And I'll finish by kind of tying all this together, saying that from the outside, we can see these end consequences of things like disturbed social relations, academic failure, unemployment, that might cause well-intended people to say, oh, you just gotta, pull your stuff together, you just gotta snap out of this and so forth. But that this is just the end consequence of numerous things that have happened to the brain, leading up to that. So before that, there's these altered emotional cognitive responses. And before that, there's altered neuronal circuitry, changes in the communication of one neuron with the next synapses, changes in neurotransmitters that are important for that communication, among many other changes. I'm just kind of highlighting a few that have a lot to do with the imaging we just saw. And not everybody responds the same. There are all sorts of risk factors that can affect each individual's vulnerability to different kinds of influences, including their genetics, but including environmental things that can cause epigenetic changes and other changes in like the hormonal axis that is regulated by the brain and so forth. And some of these happen very early, even before birth, not only in the case of genetic ones, but even some of the environmental influences that happen in the uterus. But they are still setting up vulnerabilities for things that happen later that then lead ultimately from these brain changes physically to what gets observed in these final stages as symptoms or reported by the patients as symptoms. And so that gets back to kind of the very beginning, which is that there's none of these things are just quote unquote, in the mind. These are all things that are happening in the body and at least in the brain, in many cases, because the brain is so integrally tied with many other systems of the body, affecting other things like the immune system, the gastrointestinal system, and so forth. And so that we have a few minutes left for questions that kind of cross the latter part of the talk or things that cross across these different themes and different kinds of reflections of this. I'll stop there and thank everybody for their attention up to this point.
Thanks, Dan. Dr. Ko had a question. She wanted to know if you've got a clinical practice and which patients are referred to you.
Yeah, so I have two kinds of clinical practice. I trained first as an internal medicine physician and got boarded in that, and then got boarded after that in nuclear medicine. And so at UCLA, most of my clinical time is spent in the nuclear medicine side of things. Although there's a lot of overlap, as you can imagine, especially when it comes to nuclear medicine studies of brain, like these brain PET studies. But I also have a clinic called the Brain Wellness Consultation Service that is specifically devoted to evaluating patients who have these kind of complaints that may have complex interactions between different internal medicine conditions, different neurological conditions, some of which may be better elucidated by getting certain kinds of brain imaging. And part of the question becomes, would this be someone who would have potential benefit from brain imaging, and if so, which kind? And then also working together with referral for all sorts of other kinds of specialists, neurologists, psychiatrists, psychologists, internists, that can, with their own sets of expertise, be able to help work with us to come up with a fully integrated report. And so we'll have a final report that takes all those different kinds of information that we get from that evaluation and put it together, including, if it was done, brain imaging information.
And there's one more question, if you have time. Is there anything that can be done for chemobrain? For example, a patient is still being treated with immune therapy. Forgive me if my pronunciation is off, but it's Hylecta, and estrogen blocker, Lupron, when having issues with memorizing, concentrating, having brain fogs, or getting tasks done.
So that's a complicated question with a complicated answer. So if you email that to me with the name of the person, or maybe they can email you or chat to you privately their email address if you don't have that.
Yeah.
Then I can respond to them by email with a more complex answer than the time and audience that we have here would really be beneficial for, I think.
There was a question about if this talk is being recorded and can we receive it. Yes, the talk as well as all of our monthly wellbeing webinars are recorded. They're available on our website, which is uclahealth.org/integrative-medicine. That's uclahealth.org, and I'll put it in the chat, /integrative medicine. And there's one other question, Dan, from Julie. Are you familiar with Dr. Dean Ornish currently directing randomized control trial to determine if lifestyle changes can reverse early stages of Alzheimer's?
Yes, and that's probably a good chance for you to give a plug for something that's coming up and very soon. That is his keynote.
Yes, Dr. Dean Ornish is our keynote speaker at our inaugural conference on November 5th. And I'm going to put in the chat right now our website if anyone wants to see the recorded. It usually takes a couple of days to get up on the website, but you can check back there for the recording of this webinar. And we're right at